republic for which it stands, one nation, under God, indivisible, with liberty and justice for all.
Is Serene coming?
I don't know if Shireen's gonna make it or not, so.
Well, I'll join you guys.
Come on down, Ken.
I don't know if it's legal, but-
Hi, Teresa. I intentionally took the
Okay. We have, pledge of allegiance, we have public comment. Rhonda, are you here for some input?
I am.
Okay, come on up.
Where am I going?
front and center.
You can go, yeah, you can go right here. That way they get a better look at you on the camera.
Oh, yeah, that's what I want.
On TV.
So where am I supposed to go up here?
Right there, right
Right here.
somewhere.
There she is.
You don't have to stare in the light, but there you go.
There's been an ongoing issue with people going through my yard without getting my permission. I've been going around and around with mental health about this for a couple years, and it's just been a real headache for me. Yesterday I came home, somebody had moved a bunch of stuff in my yard, well, some stuff, and opened that gate and went through, and it was obvious, so I went over to mental health and I let them know, look, we've discussed this before, I'm very much not okay with this. I don't want people walking across here, and the girl said, well, it's nobody from mental health. It doesn't have anything to do with us, and I said, I think you're mistaken. That backyard belongs to mental health. Nobody else claims that backyard, it goes with mental health. And so I said, please let everybody at mental health know this is not okay. I went on my way, and I came home to somebody driving a tractor across my yard. And I had a little puppy in the kennel right there where the tractor was. That puppy came out of a horde in Christmas Valley. And when I got him, he was shaking and peeing all over himself. He was a total mess. In the last couple weeks, I have got him a little less scared. Having that tractor go by there, put that dog in some real serious trauma. So I decided this morning that I would take my car and put it right there, so the person driving the tractor had to talk to me just while I got that puppy moved. Thing is, I got the puppy moved before the tractor person came back, so I moved the car. I'm not trying to be poopy. I even put please on the note. But moving forward from here, the disrespect that has been shown to me on my property, I think is outrageous. I cannot imagine that anybody in this room would put up with what I put up with. At one point yesterday, the girl at the desk at mental health told me to call the cops on the guy on the tractor, and I said, I'm not gonna do that. I wanna work through this, and I want people to know it's not okay. We were at a point for a long time where it kept happening, and I kept going over there and complaining, and it's my yard. We were at a point where I told the people at mental health that if you get permission, I will allow this. After what I was put through yesterday, the way it made me feel disrespected, disregarded, and like nobody cared how I felt on my own property, I do not want anybody going through my property anymore.
I have a question. Is there an alley between the two?
There's an alley and then there's my property, and right on the other side of my property, there's a gate that goes in there. There are other ways to get in there. Before, when I talked to some lawn guys, or I'm not sure who they were, but they were taking care of the lawn back there, they said they understood, and the lawn is so small, they used weed eaters. They went through another place without going through my yard, they walked in there, they weed eated, and they left. Now I understand that you can't do that with a tractor, you can't just go in through, hold a fence, but as far as I'm concerned, the disrespect and the absolute disregard for my feelings on my property, I don't want anybody going through there anymore. So that's why I wanted to talk to you guys. This isn't the first go round with total disrespect that I have had from mental health, but this is the issue at hand. And I just want to know what else I have to do to stop other human beings from coming on my property.
We hear you loud and clear.
Thank you, I really appreciate that. I thought I was heard loud and clear before, but I had to take it to you guys.
Is this happening on the other side of the alley? Because I'm not understanding.
Yes, yes, the other side of the alley, there's a piece of property, and then there's my kennels right there.
I'd be happy to address them.
Okay.
First off, I'm sorry that our maintenance crew didn't talk. We reached out to Andy Parker to get his permission to access the property. We had a leak. We had a big leak in our plumbing problem. That's why we had to.
I've been in contact with Andy over the last day, and he did not say one word about anybody getting permission.
Well,
I covered my bases.
that's great. I'm sorry that you did not get that. We did not talk to you. That's our mistake. So we apologize. The purpose was to fix the leak. That was the only way.
Like,
Certainly,
honestly,
we understand that it is your property and you do have access to that. I thought they had talked to you. My apologies. Okay? There was no intent to disrespect you.
oh, I totally understand that. I just can't imagine, and I have nothing against Ken. He's a good dude, really. Or I probably would have went out there and flipped out while he was doing the tractor. But here's the thing. I just can't imagine like everybody not checking their boxes or whatever before somebody drives a tractor through somebody's yard. Like, I accept your apology. I'm not gonna drag this out. I'm not gonna go on Facebook and slam everybody and make a federal case out of this. But like, how am I gonna tell that little dog? How about tell him you guys are sorry?
Again, I apologize. You have our apology.
Thank you.
Okay. Thank you, Rhonda.
Yep.
Next on the agenda is the approval of the consent agenda. Has everybody had a chance to read the minutes?
I so moved. We approve the consent agenda.
Second. Moved and seconded to approve the consent agenda as presented. All those in favor? Aye. Passes unanimously. Moving right along, March 2021 financial report.
Okay. I trust everyone has gotten a copy of the report that was sent out to you. The detail as well as the main report that was. Okay, that didn't work right. Month of March, we had a good month. Our volume, if you look at the volumes here, we were down a little bit on the acute year over year. That's pretty consistent with what we have been experiencing, but not just us, what most other hospitals have been experiencing throughout the country. Our acute volume is about 20% off of what it was last year. Of course, what makes that difficult to predict is what is next year going to be like. Are we going to have a big surge of patients? Hard to know. Our clinic volume is down about 11% year over year. Is that because patients have been anxious about coming back in? We're still not quite at February and March. March was up again. We're a little bit, so we're seeing a trend of increased volume, but it is down about 11% for the year. Where we are seeing a difference is our outpatient services, and that has continued to be growing. As you can see, we're up about 12% year over year. So that is a strong positive for us. And you can see that graphically in these drawings. Gross patient charges. We had, I think it is our biggest month ever. And we are seeing that both in February and March. And April continues this trend. It's been very busy. Several times in the last 2 months, Teresa has had to advise me that we are diverting patients. We are too busy, largely because we don't have enough staff, but also we are pretty darn full. So we were on divert yesterday, if I recall, or was taken off yesterday.
No, came off today, we
Came
went
off
on the day before yesterday.
Are we out of rooms too?
No, we weren't out of room, but we couldn't accommodate, the staffing. And, we have a really strict, in Oregon, we have a very strict staffing law, RN and CNA staffing law that we have to comply with. And so basically, the law expects us to go on diversion if we don't have the staff to care for the patients. And the tricky part in this day and age is that other hospitals aren't taking patients. So sometimes we go on a diversion and we still have to take the patient because there's nowhere to send them. We called, a couple nights ago, we called like 10 hospitals and couldn't get the patient.
I heard St. Charles was full.
Yeah, and it's the same, and like I said, 8 hospitals turned us down, so, so we ended up, the day we went on divert, we ended up admitting the patient out of the ER, so, but we are complying with the state law and we do our best to have enough staff to care for the patients if we can.
A lot of times it's staffing. And that even if we're other facilities, if they don't have enough staffing, they have to comply to the same staffing laws. If they don't have the staff, they can't accept the patients.
Do we ever get patients to work with us?
Not really. Sometimes, I don't know that they're on diversion from Cedarville or Alturas, but I mean, we do get patients sent to us from them. It's, we staff for approximately 10 to 12 patients, depending on how sick they are. That's what our staffing is set up for. So when we have 17, 18 patients, if that stays for days on end, we just don't have the depth to accommodate that. Pretty soon everybody's worn out because they've already worked a lot.
So when we look at what's going to happen going forward, if we do continue to keep the census at a higher rate with a lot of health issues that require additional care, we're going to have to change our staff to accommodate because this may be the new norm. It's really hard for us to predict. So we do see that fluctuation, but we did have a big month in the month of March in terms of charges, in terms of revenue, or rather collections. We had a little bit drop in year over year, but I think that Susan would be pleased. She wanted to make sure, and I think I sent it out to you, that our April collections was $3,036,680, and I won't count it.
It's a steep curve, but yeah,
It continues to be
that is the right direction.
headed in the right direction. That's correct. They did a great job. So thank you. Days cash on hand came down a little bit, but above where we were. We look at our net income. Good news is for the month of March, we had a $310,000 month. Good. So February and March have been stronger months for us. Partly because of our revenue and our expenses continue to about the same. As you can see, these are the comparison of 2 months and then a year to date. We still have a lot to make up, but a large part of that will be made up with the PPP loan forgiveness. So at the end of the year, we will end up having a positive year, is what we expect. The PPP loan forgiveness application has all been prepared, all ready. It's anticipated we will be granted that. There are still some qualifications that don't have to be defined until August. We'll be able to take that. That's what our auditors are advising. And they're reviewing all of the hospitals they work with for that same issue. I don't think there's any questions about any of this. You saw the detail in our application, or the more detailed information. Our balance sheet had virtually very little change year over year, month to month. Okay. Lakeview Gardens. Lakeview Gardens, we still struggle with the inability to admit patients. We had a patient, someone had gone to the gardens and was tested positive. And then we had to once again go into testing everyone weekly and not being able to admit anyone. So when that happens, it makes it very difficult for us to run the business. So we have virtually all of the residents have been vaccinated, but we still, even with all that vaccination, we have to follow state guidelines and limit admission. So what happens, we just stay pretty much static in terms of our expenses. We did have a little bit of a reprieve in our contract labor, but we had a little bit of an increase in our wages. Okay, any questions? This is our medical supply organization. We had a little bit of a drop here, largely because we talked about some of the software and some improvements that we spent money on last month. So we have, that's where you're seeing that expense. Otherwise, we would continue. Our revenue continues to be strong. Once we start hitting that $30,000 a month, that's a real positive for us. We're also planning on moving. We've given notice to all the necessary parties, so that we'll be moving to the new building as of June 1st. Provided the creek doesn't rise, I think.
Is that the timetable to move the business officer also?
Good question. The holdup with moving us into that building now has been our connection with Hunter Communications for our data. That was a delay. We did finally make the final connections because, as you can imagine, without the data we don't have telephones, we don't have the computer systems, we don't have door badging, we don't have all the components that you need to have. So the heating and air conditioning system is finally working. We are hoping to move the business office sooner, because there is also added pressure since the town of Lakeview has asked the disaster unit to move out of the Lepley firehouse building that houses both, well, police, the disaster unit, fire department. So the disaster unit is hopeful that the business office will vacate that space so that they can have a training room where they can set up there and practice their exercises. So we're moving it as reasonably quickly, but we're not going to race.
But it'll be done by June 1st.
Is our expectation that it'll be sooner than that, but probably not later. Any questions about any of this? I didn't hear any questions.
No.
No.
Okay, thank you.
Next items are the unbudgeted items, the Hercules patient repositioning system and the Bariatric Bed.
So, it's clear that when it came to budgeting this past year, we did an abysmal job. It didn't help that COVID gave us all sorts of things to buy that we hadn't planned on. There were a lot of them. The couple things that we have here, that I've sent you information on. One is the bariatric bed. One of the things we're finding, as is happening across the country, but Lake County is experiencing it just as much, is that we have larger and larger people. And that means that when we buy a bariatric bed, and if they're designed to hold a person who's in excess of 300, maybe 400 pounds, it's a very difficult, it's hard on equipment, it's hard on all the systems that we have. And while they're designed to handle the extra weight of that person, it stresses them. And so we have a bed that we bought for when we opened the gardens, and it, part of the fund is on its last legs. And our problem is that if it breaks, we can't put the resident on the floor. I mean, that's not good care. So we need to replace the bariatric bed. We were able to find a $20,000 bed for $13,342. It is a demonstration bed, so forget it. But it's still, these beds are not cheap. Yes, sir.
The question I had, Charlie, if in fact you don't have someone that has that weight issue, can you use it for other purposes, like a normal bed?
Yes, you can, but we're finding time and again that they get used.
Yeah.
And sometimes they get
But
frequent.
it's not gonna sit vacant just because it's that bed and we don't have that size patient?
No.
No, okay.
It will be used. And if we have to move, if we don't have a person that needs that size of a bed and we need a regular bed, we could bring that in.
Sure.
And hold it for someone that does. So I would recommend that it is prudent for us to buy, the current bed is not broken, but it is, the maintenance crew is not able to get any more replacement parts, and they're just not sure how much longer it will last. We're gonna probably have the same problem with our lifts. Even though we buy lifts that are able to accommodate large people, they still get strained. These motors don't last forever. It wears them out. So we'll have to take it. But I recommend that we consider that. I'd like to show you something about the next option. And that's what I correct a little bit to get that email.
I think so.
That's how
Oh dear.
So it's linked to me, so I don't think it might not open it.
Well, then if that's the case, you won't be able to see the video that I was hoping to be able to.
Sure.
But this next option is, Teresa could add in a little bit if I don't have it correct. So the Hercules bed, that sent you information on two different types of equipment. It's a positional system. Pardon?
It's really not a
Precision. So what this does, I was gonna show you the video, and I'm sorry,
Yeah, we will try this one on my computer and drop it into the folder.
because,
Yeah, let me see if that'll work.
so one of the things, for those of you that have ever been in a bed as a patient, one of the things that you find is you start sliding toward the end of the bed. No matter how you are in bed, you keep sliding toward the end, and if you keep sliding, you go off the other end. So that's why we have headboards and tailboards, so that we can keep people from doing that. What frequently happens is that as the patients slide down, nurses have to come and pull them up. So the Hercules group, or the Moral group, developed this Hercules process to try and accommodate that. And what it does is it's a conveyor that just pulls people up with a little motor. It has longer sheets. It's designed to accommodate most patients. But what it does is it dramatically cuts down 1, 2 nurses moving somebody. So one person can do it, push a button. 2, it cuts down on the pain of people's arms when they pull them up. If you're an older, frail person, that's not very comfortable. And you can hurt somebody a little. Let's see if I can. Thank you.
Hey, do you have a few minutes to give me a hand? Yeah, I'll be right there. Sorry.
Boosting patients up in bed like this is about to be a thing of the past. Let's go see how. It started with wanting to completely eliminate boosting procedures occurring with bedside nurses.
I look patients about 10 times during a normal shift. Each time it takes 5 to 10 minutes, and I have to go find somebody to help me. So, no, not exactly what I went to school for.
So we began to think creatively. Starting with the inspiration from an automated pool cover, we thought, what if the sheet itself could boost the patient? With each new concept, we would solicit feedback from nurses in the field who either quit the profession or are on their way out because of the toll it was taking on their bodies. It needed to be small but powerful. Every patient is unique, so the device had to cover a wide range of situations while keeping the patient safe and comfortable. It needed to be universal because there are so many different types of beds on the market. Our device had to be a perfect fit for all those types. And lastly, it needed to be extremely reliable, easy to clean and maintain, so we designed it with precision engineering discipline. And what we ended up with is a product that would change the nursing industry forever. It's called the Hercules Patient Repositioner.
Hey, how are you?
Oh, pretty good.
Good, make me comfortable.
Thank you, I appreciate it.
How's that?
Oh, it's much better. Thank you.
By simply pressing a button, you can do what normally takes 5 to 10 minutes in less than 10 seconds without any physical effort. The Hercules Patient Repositioner only has 3 components that work together to do this. The drive unit, which is the brains and muscles of the system, the simple replacement of the mattress cover to keep the sheet aligned, and a special sheet that is twice as long as the normal sheet, which allows for 10 to 12 patient repositions.
The results speak for themselves. After implementing Hercules in hundreds of hospitals, every facility has experienced 100% elimination of boosting injuries, a significant reduction in caregiver turnover, over a 50% reduction in infection exposure because less people are required in the patient's room, and a decrease in hospital-acquired pressure. And yeah, we're pretty proud of those results. Typical bedside nurses spend over an hour of their shift boosting patients, but now that can be done in a total of 2 minutes. Less time boosting means better patient care, quicker response times, and healthier nurses with improved morale.
So now, we're doing something about nursing burnout. Our goal always with this product was to make life safer and easier for nurses and patients. And Hercules is accomplishing that.
We have these in all of that?
No, we got to the trial, and I'm telling you, they would probably break my legs if we took them out of the hospital. They are in love with them. So we just have 2. They are sure that we need a lot more, but to start with, I didn't want to take the trial ones out. It kind of got really popular during COVID because in the COVID room, the nurses in there by themselves in isolate because the patient's in isolation, so it's a lot harder to get help. So the boosting injuries and the turning injuries in the COVID area are much more predominant. So that's when I started paying attention to this, but they're using them all. They plan which patients need this the most, and like I said, we just have the 2 trial repositioners right now.
So you're proposing we buy the 2 trial ones?
I budgeted for some more next year.
Good.
I did see that there's 2 around $6,500 a piece. And then there's another sheet that listed one type 3 quantity and another type 2 quantity.
Because they're for different beds.
So are we going with that extra 5 or just a 2?
No, at first I thought that maybe it made sense to see if there's always the possibility that there will be more COVID dollars that are coming about. I received notice today about another tranche of potentially close to $500,000 for rural hospitals that might come up. I don't know all the requirements for that, so I thought, well, this is really a lot about, are we delivering the best care we can, and this is an opportunity for us to use those dollars for valuable services, things that really improve the level of care that we're in. Because after all, we shouldn't be spending it frivolously, but rather ensuring that our community gets the best care we can, and that our staff, my goodness, it's hard work. And if we can help them focus more on taking care of the patient, not just the physicality of taking care, that's a good thing. That's why I have the 2 there, and I'm recommending, after Teresa and I talked a fair amount, is that we go with 2 beds and try to deal with other beds in the next fiscal year. So I'm recommending that we, 1, purchase the bariatric bed for $13,342, and then we will purchase the 2 Hercules patient repositioning systems for $12,090. These are non-budgeted items. We really didn't know about them. Well, we couldn't have anticipated them when we were developing the budget.
Protecting our nurses' backs and other things. We get a lot of back injuries, back moving people. So it's money well worth.
I think that if you look at our workman's compensation reports on the frequency of back injuries, it has dropped precipitously by the addition of some of these kinds of tools. The lifts in the rooms has made a huge difference in the number of people that are harmed by this. We still have some people that try to help somebody as they're falling or help them, they hurt themselves. But it is important that we focus on ensuring that we're getting them the best care and that they're not hurting themselves.
So move that we authorize the purchases of Hercules patient repositioning system for 2 of those, and Bariatric Bed 1. $12,090 and $13,342.
I'll second with a question. These are unexpected expenses, and we incur those, fully agree. In our budget, we anticipated X dollars for purchases. Are we still within that budget, or are we over
We're
the top?
significantly below that.
Good.
There are many things that we were planning on doing. We just will not get done this year. They need to be done, but we won't be able to get them done before the year's over. It's inherent, even when we start July 1, looking at purchases, we know that as much as we need it, sometimes these things take longer than we anticipate. Our nurse call system, we have been planning on replacing our nurse call system for 2 years, maybe. This is the new system we put in when we built the hospital. And what we are struggling with is, first off, our system that we have, there are many, many upgrades that we could take advantage of. And the service is difficult, and you have all those kind of things. Well, as we look at different options, we have to look at the costs carefully, we have to test out or look at the demonstrations of different vendors, getting them here, showing their materials, finding the best prices. A lot of times, we're too busy with other things to be able to properly give it our attention. So that doesn't change its importance. It's just hard to get it done, and that's a several $100,000 purchase. So we want to give it all of the evaluation properly that we can. And we budgeted for it, but we're not quite yet sure. It's possible in the month of June, we'll have made a selection. I mean, that still is possible, but we have enough other items that we have not spent. Does that answer your question?
Yes. I just wanted to make sure that the public that's watching us know that we stand within our budget.
Oh, we're within our budget.
So my second,
Well within the budget.
so my second still stands.
So it's been moved and seconded to authorize the purchase of the Hercules patient repositioning system and Bariatric Bed at the stated price. All those in favor? Passes unanimously. Okay, the next item is our budget meeting. Dave?
We do. I want to make sure everyone is aware. It is May 19th, from 4 to 7. It will be in this room. We will provide lunch. Make sure that our new chief financial officer, Ed, will be here. He was going to start.
Is it 4 o'clock?
I meant 5 o'clock.
Five.
My
Five.
5 o'clock.
You met dinner?
Like I said, it's been a long day, you know, lunch sometimes gets missed. What can I say?
So it's 5 to 7?
Yes.
5 to 7.
May
May 19th, it's a Wednesday, I believe.
Yes, Wednesday.
So, we thought Ed would be here on Monday, give him a chance to look at what Joey has prepared. I've had some input on that. We've had department heads. Everyone has been providing us input. I'd like to try and get that out to you after Ed's had a chance to look at it, give him a fair chance. Sometime next week, in advance of the budget meeting, we will probably, even if we get it out to you, it'll be a draft until we get to the meetings, modifications. The original projections were based on through January of 2021. So typically what we'll do is we'll take 6-7 months and then project that over the 12-month time period. We do our projections, and then now we have more information. We could do it maybe on 8 months, maybe even 9 months, close enough to get a better estimate of what we think our business will look like. Of course, when you look at our results, our budgeting process isn't always as accurate, but you know, part of that is who would have expected COVID to have such a significant impact? Just so just want to make sure everybody's prepared for that.
Okay. Next item on the agenda is Goose Lake Medical.
So that's what we talked about in the financials. I bypassed.
Yes, okay.
Sorry.
Good. I noticed that. Dr. Foster, the medical staff update.
Yeah, we didn't have quorum, so I don't have any updates for you this month. Nothing new.
Nothing new to report.
Yeah, nothing for medical staff. Dr. Chen, our intern, has started this week, so that's cool. We've seen patients in the clinic, and we'll be here 2 weeks every month.
Every
He's
other
already
week?
had a couple of inpatients, couple of admissions.
Is it every other week? Or?
2 weeks on, 2 weeks off.
Oh.
Yeah, real nice guy, very thorough. That's one update.
Thank you, Dr. Foster. Okay, risk management. Sean, you're up in center court.
Thank you, sir. Last meeting, I was asked to provide some more detail on our incident reporting, what we track, events that are of concern to us at the moment, and what we're potentially doing about some of those items. If you take a look at the packet in front of you, the chart there on the behind the title page shows we track roughly 30 different types of events over 4 categories. Those categories are patient events, employee-related events. Sorry, that's taking me away.
You didn't get one?
Complaints and non-patient related events. Those events are tracked over every facility that Lake Health District helps manage, whether it be DME, one of our health clinics, the hospital, the Altruist Clinic, or public health or public wellness, or Lakeview Gardens. Each of these events can be further broken down by the location with which, or where they happen, rather, I should say. Gives us an idea of what kind of events are happening more frequently in certain areas versus not so much in others. However, I don't want you to concentrate on numbers so much, because sometimes numbers are more of a function of us catching those particular items and stopping them before they happen, or something that may not be quite as important. The 3 major topics that I will talk about today, which are of concern to us, have to do with falls, patient and disruptive behaviors, and workplace violence. In general, along with some of the information I provided last meeting, over the past 5 years, we've had a decrease by quarter of reported events. Back in 2016, 2017, we had approximately 130 events per quarter, which is very high and kind of throws our 5-year percentage off, unfortunately. But as you can see from the chart there, we've gone down significantly. We're down to about 70 events per quarter. Number of reported events per quarter for this last year. Beginning of the year again was high. Right there at the start of COVID, not a lot of people knew what was going on. People were still moving about the country, going about their business, getting injured, and showing up at our facility. Census tends to drive the number of reports. The more people we have, the more our people have to concentrate on them. Sometimes things get missed. As you can also see in the chart, just like with everybody else, as the COVID restrictions came in, our reporting went down and then started to level off, and has now started to climb a little bit with our census climbing again. Falls are a concern for any healthcare agency, regardless of whether it's a long-term care facility, a hospital, a clinic, and they can happen everywhere. Doesn't necessarily have to be with a patient. It can be with a customer, a visitor, or even our own staff. We've had a couple incidents where individuals have actually fallen in the reception area. Other incidents where they found an individual that was a patient who had slipped and fell outside on the sidewalk, just misplaced her foot. The average age of individuals that are falling in our facilities is roughly about 63 and a half years old. And it coincides with the national average, which is right around 65 years old. As you can see in the chart on page 3, Lakeview Gardens has the highest number of falls. And it tends to happen more so with our aging population. Most often those falls happen as they're trying to self-ambulate between their beds and going to the restroom. They want to remain independent. They don't want to call for help. So they'll get up, they might slip off the bed, or they might lose their footing on the way to the bathroom, or while attempting to adjust to use the restroom. But those are just similar to that. In acute, we had 17 over the past 12 months. And I'm sorry, 15 of those 17 actually happened in between the patient's bed and the restroom. They'd get up when the nurse wasn't present, they wouldn't hit the call button. Or in one case, I don't remember the particular patient, but our nurses actually caught the patient's visitors trying to assist the individual out of bed without calling for help. People are highly independent. They don't want to ask for help even when they are in our facilities. Part of the reason we track patient behaviors and disruptive behaviors so much, those are two specifically related to the patient reporting fields, is the tendency for those to potentially become workplace violence issues. Recently, both the state of Oregon and the federal government have been working on legislation having to do with workplace violence in healthcare. State of Oregon mandated Senate Bill 823, which has to do with a safety assessment of our hospital facilities. And I can report that that assessment has been completed for all our facilities and already reported up to OSHA. We found nothing out of compliance in that report. Congress's HR 1309 is still being worked on. It has passed the House, and they're still working on passing it through the Senate. I'm sure we'll see a bunch of new regulations come out with that one. Patient behaviors can range anywhere from individuals that aren't quite sure where they are, or as I believe we call them, wanderers. They tend to have issues where they forget where they're at and they want to leave, and it's not necessarily medically possible for them to do so. In one instance, one of our nurses got punched twice by a elderly female because she wanted to leave and just wasn't possible. We had a fairly major event back in February. An individual called the emergency department late at night, explained to them that he had fallen off the wagon, that he was going to show up and be a handful. So our emergency department alerted our security and had them standing by. This individual came in with his wife. He was loud, obnoxious, abusive, and rude the entire time. And then when our staff wasn't doing exactly what he wanted or moving fast enough, he turned around and walked into the room that he was occupying and decided to punch a hole in the wall and then decided to leave AMA. For those that aren't familiar with that term, it's against medical advice. In this particular case, the individual did not sign the AMA form, he just wanted to leave. He got dressed and took off. We did have a root cause analysis after that event, and we actually included the hospital security director as well as the county sheriff himself, and obtained some further guidance on how we might prevent some of those events. We've also taken other aggressive measures in respect to workplace violence. I'm sure you're familiar with the EVADE program that we use here at the hospital. It's a de-escalation and self-defense program designed for healthcare workers. Every employee here takes it at some level or another, depending upon their engagement with the public. Security takes it at the highest possible level so they can manage situations up to and including when law enforcement has to be called. We also have a workplace violence committee. We review any events that come up regarding workplace violence. And we also have our hospital security. What a lot of people don't realize, you only see the uniform security during the night shift hours, but we do have security here 24/7. The plant operations manager, as well as another member of his staff, are acting security during the day. Let's pretty much it for my report. Yes, sir.
Have you noticed any change since we've had security staff? That's something we haven't always had. Do those numbers reflect that security is beneficial?
Yes, sir. With the security implementation, we've seen some of the events go down, but likewise, we've seen other events start to come up more often, particularly ones where individuals are under the influence. My personal belief is it has a lot to do with some of the laws that were recently passed in the state, which changed the effect of using those items or having them in your possession. And for the most part, people tend not to care once they are in that particular state of mind. That's actually a national trend that's growing regardless of any state's laws. They're seeing more and more individuals with violent tendencies or just total disregard for others showing up in healthcare facilities.
Thank you.
Thank you, sir. Appreciate it. Okay. Next on the agenda, Teresa, you're up with the nursing report.
Well, I'm happy to report that the two areas that last month we talked a little bit about needing managers in surgery as well as cardiopulmonary. We did get an interim manager for surgery. He's been here now a couple weeks. He's doing very well. This is his job. He doesn't go any place to stay permanently, but he has a lot to offer because he's been many places and he knows the regulations really well. So we're seeing some transition in some of his decision making and some of our processes. So the other thing is we did interview a cardiopulmonary manager and offered the job as well, and he accepted. He's probably a couple months out. That's the disappointing part of it, but I'll be excited for him to come on board. I think he too has a lot of experience in varied situations in hospitals. I can let you know that we still have a nursing student doing her final semester here from the OHSU program, and we still have our KCC student in her first year, also working within the nursing staff. So that's still going well. And I just realized I wish I had brought the patient satisfaction score results for the first quarter of 2021. For the first time ever, we scored above the national average for critical access hospitals in every single one of those categories. So I was extremely proud of my staff because the first quarter of 2021 was a really difficult one for them. We've had some really, really difficult and heavy patients, and we've had high census. So that was really great. We hope to sustain it. That's the next. So those are my quick items. Do you guys have anything for me?
Any questions? It's good to hear good news.
Yes, we like that.
That was really great to get.
Okay, thank you, Teresa. Mr. Twait, the CEO report.
Rebecca, do you have anything that you would like to add?
Just that, on May 26th, which is a Wednesday, and on June 2nd, which is also a Wednesday, in the evening from 4 to 7, I'm going to be holding an EVS and dietary career fair. So basically that's going to give people who aren't maybe tech savvy or have access to the computer to come in and apply and talk to me about the jobs that we have available for EVS and dietary. Environmental services, so housekeeping. Yeah. So, and I will be reaching out to you all soon once we have interviews set up for our NA program, and I hope that one or two of you is able to come. So
That was May 26th and
June second.
Evening.
Yeah, and NA is for the CNA graduates, so. And that's about it.
Okay. Thank you.
So let me talk a little bit about some of the things that have been going on. There continues to be a lot happening. As you probably are aware, the vaccination process for the state is progressing, but throughout the country, we're seeing more and more resistance to people becoming vaccinated. It is, there was even a CNN article where they interviewed a representative from Pendleton talking about how there was a great deal of resistance. You may have seen that on CNN. So Eastern Oregon is leading the cause of not getting vaccinated to the extent that we would like to. I wish I could come up with a better solution. I don't know how anyone has. We're not at 50% for our over 65 plus. We do offer the vaccinations to state guidelines, everybody above 18. There are even some that get the vaccine at 16 plus. But there continues to be many reasons why people feel that it isn't necessary to get vaccinated. Some don't know if they think it's a real risk. Some people think that they may have already gotten it, therefore they don't need to be vaccinated. There's just lots and lots of reasons. And it's difficult for anyone to come up with a plan. I think I recently saw a YouTube presentation of all the living governors of the state of California encouraging people to get vaccinated. So Newsom, Schwarzenegger, Wilson, and Moonbeam, Brown, that's well, he was Governor Moonbeam, all advocating for people to get vaccinated. So it is an issue for all of us. And I don't know how we're going to get suggestions other than just we're looking to possibly get from the federal government the vaccines in smaller doses, smaller size vials, so that if we made it available in clinic, if a doctor is talking to a patient and the patient says, well, okay, I agree, we could give it to them right then. Sometimes it's convenience or lack of convenience to get the vaccination sometimes. There's just a variety of different reasons. Ken, did you have something you wanted to add?
Only that the Veterans Affairs of Klamath Falls will be at the VFW post for veterans to vaccinate on May 15th, 2 to 5. If there's anybody on the audience that needs to capture that.
So we continue to offer that service to anybody that we can. We just won't be doing the large vaccination clinics at the fairgrounds because we're not able to manage the process. We have 2 people starting on Monday, and Keogh is our new Chief Financial Officer. We'll start on Monday, and Tyson Lane, who's our new EMS Director, will be starting on May 10th.
What was the name again?
Tyson Lane. He's starting. As Teresa said, our new respiratory therapy manager will be starting in a couple of months. And we're excited about the prospect of him coming. That continues to be an area where certainly it wasn't that long ago that we really didn't have a manager. It was more about just one guy was here and then one person was here for a week and then another person was here for a week. But we have grown so much, especially as we look at our sleep lab and the other components of respiratory rehabilitation and other kinds of services. So it's a continually growing needs the care of the patients we're taking care of. I was hoping to be able to show you tonight our new website. It is almost completed. Jen and I got to look at it today. I was going to give you a sneak preview, but there were a couple of changes that you'll want to see when it's finalized. So they're in that process. We hope it will be within a week or so that it'll be up and running. We have struggled with websites since I've been here. It is, so every time you develop websites, you like to think that you're going to get good information. The kinds of things that people use our website for are essentially three things. They want to find out about our doctors, our practitioners. 2, they want to access their medical information or their bill. And 3, they want to get a job. So we want to make sure all of those things work really well. And that's not always the incentive of the website developers. No matter what we say, they don't always make work. Our job application process is now managed through our software program Chronos. And so this will make sure that as someone goes to our website, they can actually get their application put into our website, and then we are into our Chronos program. And then there's tracking and there's all sorts of information. So it isn't always just providing information. A lot of it is the connections that we have to make with other areas that are significant. Give you an example of how challenging it is. I continue to field calls at my office for Dr. Foster here. I don't know why, but some of these programs think that my office telephone number is his direct line. And they call up and ask for Dr. Foster all the time, and I say, I'd love to get him to you, but I'm not him. He doesn't even know that the number is wrong. And yet, those are the kind of things that you think, how? I mean, I know this personally. I'm just glad they don't call, the Dairy Queen. And they say, he is not here. We want to get those patients to Dr. Foster. So there's a lot of good things. So we hope to show that to you as quickly as possible. Patients want to access their medical record, get into the patient portal, and not have the ongoing challenges that we have had. We believe Cerner's going to be better. We believe that this portal will work. Even though CPSI promised for years that, oh, they're getting better. Didn't always work. So we continue to have several searches going on. If you go to our website for jobs, the list is amazing. And we are looking for a lot of people. So we had some interviews today with Teresa having announced that she will be stepping down as Chief Nursing Officer. We are actively interviewing for that position and hope to fill that before she says, no, I told you. She occasionally reminds me that, if we don't find the right person or we're not sure, would she be willing to stay on? And I think, yeah, I can tell, but I know what her husband would say. We have, as predicted, the number of chief operating officer applicants that we have gotten has now exceeded 100, I think. There's a whole lot of people that are looking for jobs. So we'll be sorting through those. Some, of course, there's no chance that someone that's coming from Boston, working in a large hospital, would be interested in the chief operating officer position. So it's clear that some are not necessarily. We also will be looking for a replacement for Susan. Susan, as you know, has submitted her resignation as revenue cycle manager, and she's agreed to stay on a little bit longer to reposition what she's capable of doing, and we are actively looking for a replacement for her. And we're very pleased and thankful that she is still helping us while we are in that search. We have struggled for a long time with our environmental services, our housekeeping. used to call it. It's a vital service, it's hard work, and oftentimes it's one of the first jobs that people take when they come into a hospital. So we have turnover, we have, as with often happens, first-time jobs, sometimes we help people learn how to do a job. And we have, it's stressful to manage people that are in environmental services department. We've had a variety of different managers. We have some people that are functioning in that role right now. So one of the things we did is through our group purchasing organization, Untitled, which is now busy purchase, we have a consultant who has worked in small hospitals who's here to help us develop the rules, guidelines, processes to make sure we're doing a better job, to help both the staff that are here and prepare us for who we get as our overall manager. So that is going to, I think, help. Sometimes we think just by practicing it, we'll get better. A lot of times it helps to bring in an expert. Use that advice. So we're in the process of doing that. As Dr. Foster said, we have Dr. Jeffrey Chen, who has started this week, or the last week. He is an internist, comes from the great state of Washington. He's worked in multiple rural hospitals. He spent many years over on the coast of Lower Umpqua. An excellent physician that adds a different component of services to family doctors that we have. And as I'm sure many of you will attest, getting in to see Dr. Foster or Dr. Gallagher or Dr. Husky, or for that matter, Dr. Graham, sometimes the wait is a long time. They're just too busy with complicated patients. And so by adding additional practitioners, that helps allow our physicians to be able to see our community timely and make sure that their problems are addressed quicker, thereby not allowing their conditions to get out of control and have to be. So we're hopeful that this will be a good working relationship. We have a couple other practitioners we are interviewing that could help complement some of the services we're doing. As you can imagine, I interview lots and lots of physicians. Sometimes we get those that say, Lakeview, is that by Chicago? There is Lakeview, Chicago. Here, and then they see Goose Lake and think, oh, there's a great big lake. When they come here and they go, where's the big lake? So,
That's a solid lake.
sometimes perception is not always what people think when they first look at us. So I don't bring up all the people that I talk to. I don't think that that's necessarily helpful. We get excited that they might come here, and then they come here and they don't always stay. So as we bring candidates, we'll be trying to ask for your involvement to help explain what it's like. Appreciate it. Dr. Chen is now staying at the new house that we purchased on Pioneer. So making use of that space. I think that's any questions? Any other questions?
Okay, that's the CEO report. Do we have executive session material?
We do. Several things we want to talk about.
So we'll during the regular meeting and go into executive session with a 10-minute recess.
Are we going to adjourn, or are we just going to go into recess?
We'll recess.
There we go.
I will work on fixing the agenda.